A 24-year-old man present to the emergency department with a fever, chill, night sweat, malaise and fatigue that started 3 days ago. In the past 24 hours, he has become shortness of breath. He admitted to use intravenous drug regularly. At presentation, the patient is shaking and appear pale. Physical examination is remarkable for the temperature 39.4 degrees C, hypoxic to 88% on the room air, jugular vein distension, bilaterally decreased breath sound at the base of the lung, and a grade 3 to 4 systolic murmur heard best at the lower left sternal border. Which pathogen is most likely responsible for this patient? So pick the point that is fever, okay, fever, chill, night sweat, malaise, fatigue. It's a very rapid onset, and the patient, okay, he admit the use of intravenous drug regularly, and there is a shaking and pale appearance, a high grade fever, and hypoxia, that the respiratory failure stage 2, jugular vein distension. It means there is a right ventricular failure or right heart failure, and the second sign is decreased breath sound. Okay, this means there is a accumulation of the fluid at the base of the lung. And grade 3 to grade 4 systolic murmuring heard best at the lower left sternal border. Lower left sternal border, it's mean here. So here we can use the tricuspid wall. So defect may be in the tricuspid wall, defect may be in the right ventricular failure, defect may be into the lung. But if we think deeply on the sign and symptoms on the use of intravenous drug, so we come to know that this is a classical case of the acute myocardial endocarditis, because the sign and the murmuring and the jugular vein distension, if we compare these two, we come to know a pathological condition of the heart, that is the acute myocardial infarction, endocarditis. So this is a classical case of the acute bacterial endocarditis. Endocarditis often is characterized by the constitutional symptoms, for example fever, malaise, chill, and the new onset of the cardiac murmur, and a combination of other signs and symptoms, for example genital lesions, osseous lesions, or rough spot in your eye. Okay, these are the signs of the acute endocarditis. Acute and subacute endocarditis can be differentiated based on the history, because the acute case will have the most severe and the sudden onset is in this patient, because the duration is only 3 days. Acute bacterial endocarditis also is seen most often in cases of intravenous drug use and in traveling catheters, and Staphylococcus is the most common cause of the bacterial pathogen associated in this case, because the patient admit that he is using the intravenous drug regularly. This means that he is using injecting something in his body continuously, so the skin bacteria which commonly present on our skin in most quantity amount, there is the Staphylococcus aureus. It get the chance if we use regularly injection, so the bacteria can enter into your blood circulation, it affect the various organs, so it's mostly affect the endocardium and leading to the endocarditis as in this patient. But let's see some other sign, let's see some other scenario of this patient. So this patient has a history of, as I said already, that in intravenous drug abuse. Okay, in the right side endocarditis, one more often see septic embolism to the lung. Okay, in case of right, if the right endocardium is involved in this case, okay, there is a formation. It also affect the mitral Okay, tricuspid wall. The tricuspid wall is also a lining of the endocardium. Okay, if the endocardium infect here or in the wall, okay, there is formation of vegetation, there is formation of embolism, and this embolism through the pulmonary valve, okay, pulmonary trunk, it goes to the lung, and in lung there are small vessel. It causes the obstruction of the small vessels. Once these vessels obstruct by the emboli, formation of the pulmonary embolism, there is increasing in the intravascular pressure or the hydrostatic pressure into the pulmonary capillaries, which leads to the formation of edema into the lung. As in this patient we can see that there is a decrease breath sound at the base of lungs, mean that is there is the formation or the accumulation of the fluid at the base of the lung, and this is maybe due to the formation of the pulmonary embolism, and this pulmonary embolism come from the endocardial vegetations. This patient is manifesting a sign of the bilateral infarct, okay, with hypoxia, decreased breath sound, and dullness of the percussion on lung percussion. Okay, it is important to note that many of the classical signs of the endocarditis, such as genuvalations, oscillus, and road spots, are seen mostly such as a complication of the right-sided endocarditis, in which the septic embolisms leave the heart and enter the systemic circulation. So we understand the scenario that the patient has is admitted that he is using continuously intravenous medications or intravenous, he's using something through intravenously, okay, and so the staphylococcus aureus enter into the blood circulation of this patient, and it then it affect your endocardium, okay, right side endocardium, including the tricuspid wall, because here we listen some sound that is the lower edge. So here there is a new onset of the murmuring at the tricuspid wall location. Okay, so number first sign this one, and there is formation of vegetation, and this vegetation cut off as formed as emboli and went into the lungs, causing the pulmonary edema in this condition. So our most specific onset in this case is staphylococcus aureus. Okay, and what about the enterococcus faeciali and other bacteria? Enterococcus faecilis and the Haemophilus ephrophilus and Streptococcus bovius and Streptococcus viridae, these are the bacteria which mostly attack on your heart when the heart has already some abnormality. For example, in some cases of the congenital heart defect, or the patient suffer already with endocarditis, and the patient when again come to, you can say that in susceptible person, and in those persons whose heart is not healthy, completely healthy, so those patients will affected by some bacteria, that is viridae, bovis. Okay, they are the bacteria which cause after those abnormalities. Okay, so these bacteria, they causes the acute myocardial subacute endocarditis. Okay, so they cause subacute because if we divide the endocarditis on the sequence or the severity, we have subacute and acute. Okay, so in case of acute, we already said the bacteria which commonly affect, that is the staphylococcus aureus, and in case of subacute, the other bacteria like enterococcus, okay, and like streptococcus bovis, streptococcus viridae, okay, all these bacteria which causes the secondary heart endocarditis, or we can say that they affect after some congenital abnormality or after the first attack of endocarditis. Thank you.